start.
Yes, sir.
Hello, Peeyush.
Good evening, sir. Good evening, sir.
Hi.
Good evening, everybody. Good evening, sir. Kapoor, sir. Good evening, sir. Rajan, sir. Good evening, Varshney, sir. Hi, everybody.
Good evening, everybody.
Good evening.
Good evening.
Good evening, sir.
Hi, Peeyush. How are you?
I am good, sir.
Okay, it's 7 o'clock. We can start. Good evening, everyone, and welcome to the 15th edition of Jaipur Surgical Tutorial Masterclass. The theme this time is management of CBD stones. For those of you on the faculty and the students who are joining for the first time, just a brief introduction about these masterclasses. Actually, we started an online education portal called Jaipur Surgical Tutorial more than 3 years ago. This portal is managed by my colleague, Dr. Anand Nagar, who's an associate professor of, he's now a professor of HPV surgery at my institution. And in this, we conduct a session every Saturday morning, 9 to 10, where students present cases. Sometimes they present operative procedures, and once in a while, we have lectures by faculty also. So in between the sessions, I will project details about Jaipur Surgical Tutorial as to how students can join it so that they receive regular information about the sessions. In addition to the Saturday morning class, last year we started once in a month master classes where we select one topic, one theme, and we do 2 sessions of 2 hours each on last Wednesday and Thursday of the month, where we have about 3 or 4 presentations covering the various aspects of the theme, which is moderated by experts. And then we have about half an hour for an open house session, where anything which has not been covered, or if the panel or the moderator wants to ask any question from the panelists, we also get questions on the YouTube, which we will then pose to the panelists. And for all these online educational activities, the technical support is provided by the team of Dr. Avinash Tak, who is my former fellow from SGPGI, who is now a consultant GI surgeon in Ahmedabad. So thanks to his team, who manages all the online support. All the videos of all the Jaipur Surgical Tutorial sessions, all the previous master classes, and all the annual Jaipur Surgical Festivals, which we have already held 3, and the 4th one is going to be held in December. Again, I will project the information about that. They are available on the website of Gastro University as well as my institution. So students are more than welcome to watch these videos. With that brief introduction about JST and the master classes, I would like to welcome my former colleague and one of the eminent GI and liver transplant surgeons of the country, and former head of the Department of Surgical Gastroenterology and a former dean of the SGPGI Lucknow, who has recently joined Apollomedics in Lucknow after his superannuation from SGPGI. He is going to moderate today's session. Dr. Rajan has a vast clinical experience of the entire gamut of surgical gastroenterology, including biliary surgery, which we saw a large number of cases when we were together at SGPGI. And for those students who do not know him, he has an excellent command, not only over the subject, but English and music also. So with that, I hand over to Dr. Rajan to moderate this session. Over to you, Dr. Rajan.
Thank you, Vinay. Nice to be joining JST. And let's see if we can make it a regular affair. It's a very interesting topic today. Diagnosis of choledocholysis and Mirizzi syndrome, clinical history, examination, and investigation. So in nutshell, other than treating these problems, you will know everything about that in this presentation. And may I now invite Dr. Mohammad Younis to make his presentation.
Thank you, sir.
So,
Thank you, Rajan,
sorry,
sir.
Before Younis starts, Younis, I welcome you to the Jaipur Surgical Tutorial Masterclass. Younis is a young faculty colleague at SKIMS in Kashmir. We recently met at a meeting and he showed interest, and I'm very happy that he has joined as the faculty on Masterclass. Over to you, Younis.
I am Dr. Younis from Department of Surgical Gastroenterology. I am presently working as assistant professor there. So thank you, VK Kapoor sir, for inviting me to this session. Thank you, Rajan sir, for being there. Can I start, sir?
Please.
Today, my topic is the diagnosis of choledocholitis and Mirizzi syndrome. History examination, I will focus more on the clinical aspects and investigation part. That has been given my topic. I will start. Choledocholitis is the presence of stones within the common bile duct. It is estimated that common bile duct stones are present in 4 to 18% of the patient with cholelithiasis. Choledocholitis occurs as a result of either the formation of stones in the common bile duct or passage of gallstones from the gallbladder. Choledocholitis is classified as primary or secondary according to the origin of the stone. Primary choledocholitis refers to the stones that are formed directly within the biliary tree. They are generally brown stones. And secondary choledocholitis refers to the stones they come from the gallbladder, and the composition is that parallels that of cholelithiasis with cholesterol as the most common type. What are the symptoms of these choledocholitis? Most patients with choledocholitis, in distinction to cholelithiasis, the majority of them are symptomatic. They present with right upper quadrant pain. This is caused by the distension of the extrahepatic biliary ducts, and certain mechanisms are involved, like spasm of the sphincter of Oddi may contribute to the pain, which is typically experienced in the right upper quadrant. The patient, they can have associated nausea and vomiting. Some of the called stones are asymptomatic in 10%, less than 10% of the patients. 1/3 are believed they are supposed to pass spontaneously. They are usually small stones and they pass frequently. The patients can present with obstructive jaundice. Jaundice is usually detected when the serum bilirubin exceeds 50 micromoles per liter. And it can the stones impact, and that can lead to persistent jaundice, or typically there's a fluctuant jaundice due to the ball valving of the common bile duct stones. The patient can present with cholangitis, as you know, the typical Charcot striae, obstructive jaundice, fever, and rigors and chills. And some patients can go into septicemia which can renal spinal shock and confusion. Some of the patients can present with acute gallstone pancreatitis. The gallstone transiently obstruct this pancreatic duct. This can lead to pancreatic ductal pressure and enzyme activation, which can lead to pancreatitis. The symptoms are pain, severe abdominal pain, reddish to the back, and with concomitant rise in the serum amylase and lipase levels. Some of the patients with pancreatitis, though no etiology is known, it is believed that it may be some microliths they pass and that's not picked up. They are small stones which are not picked up, and because resolution of the ultrasound is very less, they cannot pick small stones. But one problem is pancreatitis, they can have recurrent attacks of pancreatitis that sometimes can lead to severe pancreatitis. And some patients can develop hepatic abscess due to obstruction, or prolonged obstruction can lead to secondary biliary cirrhosis. Clinical feature, as you know, the patient can present with jaundice, accompanied by pale stools and dark urine. Itching may be present. The gallbladder is usually not distended, as the Corvazilla you may be knowing. The patient can present with typical Charcot striae, and jaundice can be associated with pain and sepsis, or the patient can have acute pancreatitis. On physical examination, the patient usually have tenderness in the right quadrant, and they can have icterus associated. So what are the markers that come if the patient is having infection? They can have raised TLC and DLC, and usually direct bilirubin is raised, gamma glutamyl transferase, alkaline phosphatase, And total bilirubin is considered the main laboratory index related to the risk of synchronous common bile stones in presence of cholelithiasis. When there is no jaundice, raised GGT levels has been suggested to be the most sensitive and specific indicator of CBD stones. A value greater than 90 micro units per liter has been posed to indicate a risk of cholelithiasis. But how to suspect whom patient we should suspect? Patients who are often suspected when it's a right epicondylar pain, they have elevated liver enzymes, particularly a cholestatic pattern when concomitant bile gallstones, or there is disproportionate elevation of alkaline phospholipid and GGT and bilirubin compared to AST and LT. There's a disproportionate elevate in LFT picture. What is the epidemiology? It has been found to 4 to 18% of the patients undergoing cholecystectomy. The incidence of cholelithiasis in patients with cholecystitis increases with age. Cholelithiasis is more common in females and pregnant patients, older patients, and those with high serum levels. What are the pathophysiology? As you know, there's primary, secondary, and they can be complemented by Mirizzi and hepatolithiasis. What are the risk factors like old age, bilidiverticular CBD stricture, colorectal cyst, and parasitic infection in case of OCH? There's an important previous history. They have a previous history of gallstones, previous HPB surgeries. Patient maybe have been undergone bariatric surgery, rapid weight loss, liver dysfunction, hemolytic disorder, diabetes. The natural course of the this is a paper by in the JAMA. They have concluded that the finding that in general effort should be made to treat the common bile duct stones when we are dealing with the cholelithiasis. And there's another paper in surgical endoscopy. They showed the patient present with symptomatic CBD stones after laparoscopic colostomy, even after 4 years. What is the initial workup we should do? The initial workup, we usually do ultrasound, is the initial imaging. Biliary stones appear as echogenic and round with acoustic shadowing. It has sensitivity of 73% and specificity of 91%. If there are no stones, the indirect signs are there were dilated bile ducts, typically greater than 6 mm. But there's a pitfall of the ultrasound. It has poor sensitivity because of overlying bowel gases. But the negative ultrasound usually does not negate the presence of cholelithiasis. This is the ultrasound picture. But in presence of dilated CBD, we should suspect that there is some stone. First will come the stone. As we can see, the patient with greater than 10 mm of bile duct, they have 50% probability of having the stones in presence of gallstones. CT scan, it is usually not done when we are suspecting the cholelithiasis because it is not a definitive test because gallstones are similar in density to surrounding bile. We can miss the bile stones, but it may be improved by addition of contrast. It detects, but it has indirectly can show bile duct dilatation. MRI, yes, it will has T2 wave images. It is a high sensitivity, 93%. And impact stone will as a round filling defect with crescent. It is preferred imaging modality for assessment of intrahepatic stone burden. And one advantage is we can see past the obstruction, which is a pitfall of ARCP. In ARCP, we cannot go past the obstruction. This is a picture showing cholelithiasis with gallstones. ARCP is diagnostic, but as well as therapeutic. It is to be used when we have to treat the stones, not singly as a diagnostic procedure because it has high morbidity. It is a morbid procedure. It has its complications. ARCP is recommended for patients with high probability of cholelithiasis because it's an invasive procedure and it is used for early treatment, not as a diagnostic test. US, yes, in centers or US is available. It can be used. Especially it is sensitive for small stones less than 5 mm and high sensitivity and specificity. It has no limitation of bowel gas effect. But the choice between US and MRCP relies based on the resource availability, experience, and cost. So this is an investigation I already told: ultrasound, MRCP. This is the sensitivity. Ultrasound is less sensitivity, and MRCP has the highest sensitivity and specific for cholelithiasis as well as EUS. So American Society of Gastroenterology and Endoscopy has in 2019 laid down different criteria, like high risk criteria. Then there is In ultrasound, stone is visualized, the total bilirubin is greater than 4, and patient has a cholangitis. These patients are having a high probability of having stones, concomitant CBD stones. And moderate risk like abnormal LFT, dilated CBD, bilirubin of greater than 1.8 milligrams, and age greater than 54. Based on these criteria, we can assess the risk criteria, the patient having the probability of having stones or not having stones. Usually the diagnostic approach is from less invasive to more invasive, like first ultrasound, MRC, and then we can go to invasive procedures. This is the algorithm how we manage patients, not actually manage how this is a pathway patient with suspended choledocholitis with having any of the following features like CBD stone, ultrasound, acute cholangitis, or bilirubin high greater than 4. The patient can have high probability of CBD stone. So the patient, if it's not in cholangitis, the patient can be subject to pre-op ERCP. If the patient has cholangitis, again, the bile duct has to be drained by ERCP. Or if the patient does not have the high risk features, like the patient have abnormal liver function, biochemical parameters, or dilated CBD, still we can go for intermediate. There's an intermediate probability. So the patient can go. In these patients, we usually need MRCP or EUS if it is available, or cholecystectomy with IOC can be done in these patients. If these are negative, so we can MRCP is negative, we can go for cholecystectomy. My friend will discuss in detail the management of the. I will not go in detail. So this is a roadmap. So this is a picture. On-table cholangiography by the paper from British Journal of Surgery, they have such the routine cholangiography in patients with low risk of CBD stone does not seem to be justified according to this paper. So in this paper, BMC gastro, they have such the MRCP should be done routinely. What is the between both EUS and MRCP provide a good diagnostic accuracy, but with EUS providing slightly better diagnostic accuracy and sensitivity with comparison. Yes, it should be incorporated diagnosed in patients with whenever possible, whenever appropriate, or whenever available. So now we go to my next topic, Mirizzi syndrome. It's a rare complication of the gallstone disease. Overall incidence is 0.3 to 4%. It was first reported by Kerr and Rug in 20th century. The gallstone are impacting the infundibulum cystic duct. It can cause external compression of the bile duct and the consequently chronic inflammation, ulceration, and fistula formation. This is the stone impacted in the cystic duct and it causes compression of the CHD or CBD. They usually cause inflammation and obstruction. It is detected in 0.06% to 5.7% of patients undergoing cholecystectomy. In 1% of the patients undergoing ERCP. What is the pathophysiology? Because the recurrent impaction of gallstones on the cystic duct and infundibulum, repeated episodes of acute cholecystitis, the additions are formed between gallbladder and a common hepatic duct that can lead to impaction of the gallbladder and the Hartmann's cystic duct. The prolonged compression caused by the stone results in inflammation, ulceration, and formation of a fistula in the different stages of advancement, or in some instances, enteric fistula, cholecystoenteric fistula. What are the risk factors? If the patient has long-standing gallstone disease, there's anatomical variation, long cystic duct, low insertion of the cystic duct, or some clinical features like the patient are reluctant to cholecystectomy or there's a prolonged inflammation. What is the anatomy? The gallbladder is involved. Usually the gallbladder have thick or thin walls, impact the stone at the infundibulum, at the Hartmann's pouch, or cystic duct is obliterated, or absence of the cystic duct along the cystic duct running parallel to the CHD, or low insertion. What with the bile ducts? There may be partial obstruction by external compression that can erode the duct, or normal caliber distal bile duct with walls of normal thickness, or dilated proximal bile duct with thick wall and faint walls, or it can lead to fistula. What are the features usually common in females? Average age of presentation is 50 to 70 years. Jaundice is the most common presentation. They can have fever, cholangitis, and it can mimic biliary and pancreatic malignancy. This is very important. Or gallstone ileus. The patient usually present with jaundice, elevated ALP, aminotransferase levels. In type 2 Mirizzi, they have CA19-9 is raised, which must be interpreted cautiously in patients when we are suspecting biliary malignancy. But what is the class? Max Sherry et al. In 1982, based on the ERCP findings, divided it two types. Type 1 is an external compression of the bile duct by gallstone impacted in the neck of gallbladder. Type 2 is a fistula caused by the eroded stones. Another classification of SNDs, there are 5 types. First is the type 1 is external compression of the bile duct by an impacted gallstone. Type 2 is a fistula that involves less than 1/3 of the circumference of the bile duct. Type 3 is fistula involving up to the 2/3 of the bile duct. Type 4 is fistula with complete destruction of the entire wall of the bile duct. Type 5 is present the cholecysto-enteric fistula with gallstone ileus, or with cholecysto-enteric fistula with not associated gallstone ileus. What is the difference? This is very important. The patient with has a differential gallbladder cancer, we need to rule out the gallbladder cancer. It's very common in our settings. Cholangiocarcinoma, sclerosing cholangitis, and metastatic disease. Usually, these had to be ruled out in the close differential diagnosis. High index of suspicion should be because it's a very rare, pre-op diagnosis is difficult because it is not made. Intra recognition and proper management is essential. Inadequate recognition of this condition leads to high pre-op morbidity and mortality or post-op mortality. The incidence of bile duct is high in these patients. It is without pre-op diagnosis could be as high as 17%. Imaging studies are the mainstay of pre-op diagnosis. What are the challenges we feel with the Mirizzi syndrome? It is a low incidence. There are no standardized protocols. Only 8 to 60% of the patients can be diagnosed preoperatively. It leads to difficulty in identifying the cystic duct. No specific presentation. It can have any varied presentation. There's distant anatomy and callets, limited sensitivity of the diagnostic tools. If unrecognized, can lead to bile duct injury. Clinical picture and lab findings, including tumor markers, may be misleading. Ultrasound is the first investigation we do in these cases. It may show atrophic gallbladder or dilatation of bile ducts, or thickened gallbladder walls, impacted stone, dilated ducts. This is a picture showing inflamed stone that compresses the CBD. CT is usually used to rule out malignancies in these cases. It usually visualizes inflammatory changes, bile duct dilatation, and thickness, but sensitivity is low. It often misses the stones. It helps us for detecting signs of chronic inflammation and predicting surgical difficulties. This is the CT picture showing the Mirizzi syndrome in stone compressing the CHD. MRI, MRCP is preferred non-invasive imaging technique to visualize bile ducts. It has high sensitivity for diagnosing Mirizzi's. It can detect ductal narrowing, stones, bile duct dilatation with great accuracy. It allows visualization of the other bile duct obstruction like choledocholysis. It is often used in conjunction with other diamond model to confirm the diagnosis. This is the MRCP picture showing the stone impacted and compressing the CHD. Another picture showing dilated CHD with stone eroding to the CHD, impacted stone, and normal distal CBD. This is the another picture showing choledochal fistula. ARSP is a gold standard, considered the gold standards for diagnosing Mirizzi syndrome due to its detailed visualization of the bile ducts. It identifies extrinsic bile duct compression and fistula. It can be used for therapeutic intervention like stone extraction or bile duct stenting. It has high sensitivity and accuracy, but limitation, it is an invasive procedure with risk of complication. ARSP findings in there is a filling defect in CBD. There's a filling defect in CHD and biliary and during ARSP. It is another case of this Mirizzi syndrome is showing the, this gallbladder compressive CHD with fistula. Intracholangiography can be done as a real-time guidance. It helps the surgeons intraoperatively to delineate the anatomy. Or percutaneous PTC can be done when ERCP is not feasible or failed ERCP. Offering different, it gives a good visualization of the bile duct system. It allows for a biliary drainage or stone removal using the same procedure in case of obstruction. Intraop ultrasound can be done, provide the surgeon intraop. It provides with real-time visualization of the bile ducts and surrounding and guided safe dissection. It's a non-invasive. And ICG we are using this it and use of indocyanine helps to improve the visibility of the bile duct during surgery. It helps intraop safely helps avoid bile duct injuries by clearly delineating the biliary structures. Surgery remains a preferred approach for the Mirizzi syndrome. Laparoscopic cosme was first reported successfully in type 1 Mirizzi by Paul et al. However, most surgeons do not recommend laparoscopy as a viable standard option due to the increased risk of bile duct injury and high conversion rates. Systemic review by Antonio et al. Associated laparoscopy for Mirizzi with low success rate. Considering these authors don't recommend this technique for Mirizzi. Despite these setbacks, minimalist technique in the management of Mirizzi continue to be explored. So 20 million people globally are affected by gallstones, with 11 to 21% having the common bile duct stones. Patients may be asymptomatic or present with pain, jaundice, fever, and acute pancreatitis. Ultrasound, MRC, ERCP are the key diagnostic tool for detecting bile duct stones. Mirizzi is a rare complication caused by the gallstone impaction due to dark compression. Lower diagnostic rates and distorted biliary anatomy complicate treatment and surgery. Thank you.
Dr. Rajan.
Thank you, Doctor. Just a minute.
Yeah, Dr. Rajan, please carry on.
Thank you for a nice presentation. I would only like to make a small request to you. Please don't rush through the pictures in your presentation. Let the students register as much as possible. Your pictures were good, very representative, but you simply rushed through them. That is what is not desirable for a young population trying to learn what are the tricks and trades in this game. Will we take the questions now, or will we take at the end of the day?
No, if you want to ask anything, if you want to add anything, you can do it now. We still have about 5 minutes for this session, or if any of the panelists want to ask or add anything.
Do we have any questions from the people participating here?
No, not on the YouTube as yet, but no question on the YouTube as yet. So maybe we can move on. So I think we will take Peeyush's part first, because Abhinav hasn't joined as yet. He can take the endoscopic management later. So maybe you would like to introduce Peeyush and...
How long is Abhinav going to take? Because endoscopic thing before surgery is a worthwhile discussion.
No, Peeyush is going to discuss the broad outline of management.
Okay, let's start with him.
Yes. So I'll stop sharing, sorry. So Dr. Peeyush Varshney is again our former fellow from SCPGI. He is currently at the AIIMS Jodhpur in the Department of Surgical Gastroenterology. Peeyush, please unmute yourself. Peeyush, आपका muted है. Peeyush, can you hear me?
Okay, sir. Now, can you hear?
Yes. Now share your presentation. Yes.
Is it visible, sir?
Yes, we can see.
Okay, so may I start?
Yes, please.
Thank you very much. First of all, it's a great privilege and proud moment for me to present in front of my mentors and teachers, Professor Kapoor and Professor Rajan Saxena, whom I have been trained with. Next, coming on to this topic, it seems to be easy on a first look, but when I looked into the literature, although there is not so much recent literature, but yes, there are many new things which I learned while preparing this presentation. So, although evaluation has already been dealt by Dr. Younis, I'll just briefly touch the important points in the evaluation of concomitant gallstones and CBD stones, and then quickly move on to the management. So, there is a term which has been coined for a combined gallstone and CBD stone, that is known as cholecystocholidocholithiasis. And around 10 to 18% patients who undergo laparoscopic cholecystectomy are found to have synchronous CBD stones. So they can be found either intraoperatively or preoperatively. So majority of them are secondary, and treatment is always required because they are prone for risk of cholangitis and organ failure. So pre-operative evaluation, it has to be thorough because the presentation can be as small as from asymptomatic to as worse as it can be a life-threatening septic shock. So it has to be guided by what presentation the patient has come to us, whether the patient is asymptomatic, presented with biliary colic, jaundice, cholangitis, or pancreatitis. So as to briefly summarize the presentations, these are the 5 most common presentations of CBD stone. The last 2 presentations, the cholangitis and pancreatitis, they have to be dealt seriously because there is a risk of mortality associated with these conditions. So whenever the patient comes with cholangitis or pancreatitis, a thorough evaluation needs to be done, and the urgent biliary drainage or control of sepsis has to be done if required. So these are the routine blood investigations which are routinely done before any proceeding to any procedure for a patient of CBD stones. That includes CBC, liver function test, amylase and lipase to rule out pancreatitis, CRP, bile and blood culture are usually sent if the patient is in cholangitis. Already discussed, ultrasound is the first investigations. It has got a poor sensitivity and specificity, but it can give a roadmap depicting IHBRD as well as a level of block. CT scan, it has a specific indications if the patient, if we are suspecting any malignancy or there is a complication of CBD stones like pancreatitis or any abscess. Earlier, there was a time when CT cholangiography was done, but now it has faded out because of the introduction of MRCP as well as endoscopic ultrasound. Next is the MRCP. Nowadays, it is readily available and should be done in each and every patient of CBD stone because it has high sensitivity as well as specificity. It has a chances of missing small stones less than 5 mm as well as the peripancreatic edema can reduce the accuracy. Next is the endoscopic ultrasound, not available readily at each and every center, but it has got high sensitivity and specificity when compared to MRCP on head-to-head comparison. And people have advocated that US-directed ERCP seems to be cost-effective when done in a same session for CBD stone. Biliary scintigraphy, or commonly known as hydroscan scan, not routinely done because it just gives out where a biliary continuity is there, does not give any anatomical roadmap to us. This is the summary. Most important is the MRCP, which is readily available nowadays and should be done in all the cases. And it has a drawback that it is although costly and can miss stones less than 5 mm. So there are many prediction models when the patient present to us with gallstones and we are suspecting a CBD stone. So there are many prediction models have been developed. So this was the first prediction model, the model that was developed by Lecken and Huger in 1988. That depends upon age, pain abdomen, CBD diameter as well, and the smallest gallstone diameter. And if the score is more than 3.5, that requires additional biliary evaluation. But it is outdated and faded out. The most commonly has already been discussed by Dr. Younis is the ASG risk certification, originally given in 2010 and has been modified in 2019. This includes 3 predictors: moderate, strong, and very strong, that classifies the patient into 3 risk categories: low risk, moderate risk, and very high risk. So includes abnormal LFT, age, presentation with pancreatitis, CBD diameter, level of bilirubin, ascending cholangitis, and if there are CBD stones on ultrasound or any previous imaging. So this is a roadmap based on the suspicion of CBD stones based on this risk prediction model given by American Society of Gastroenterologists. So on the basis of this, if the patient falls into the category of a low risk, a laparoscopic cholecystectomy is recommended straightforward. If there is an intermediate risk category and there is a facility of intraoperative cholangiogram or intraoperative ultrasound, then it should be done. And if it is not available, then a laparoscopic CBD exploration or a post-op ERCP may be recommended. But most common is a pre-operative evaluation with endoscopic ultrasound or MRCP, followed by pre-operative ERCP. That is the most common pathway that is being followed. And if there is a high risk, and then obviously the recommendation is to get a pre-operative ERCP. So now coming on to the main topic of management. So there are 2 conditions when the stone is detected intraoperatively or preoperatively. So most common scenario now with nowadays imaging is that the stone will be detected preoperatively. So preoperative stone straightforward nowadays the routine recommendation is to get a ERCP and stone removal. But the timing of ERCP is debated if there is a detection of stone intraoperatively. For gallstone, there is no debate that the laparoscopic cholecystectomy is standard of care. But with respect to the CBD exploration, still there are many approaches and there are many debates for these approaches that I will deal with one by one later on. So broadly classified, there are two approaches to manage the CBD stones. First is the single stage procedure, that is the simultaneous. To do a simultaneous laparoscopic cholecystectomy with laparoscopic CBD exploration if the expertise is available. Second procedure, simultaneous procedure, is laparoscopic with intraoperative ERCP. This procedure, when I talk with this simultaneous laparoscopic with intraoperative ERCP, is meant that with a single anesthesia and with either with a rendezvous technique or directly cannulating the ampulla, the CBD is cleared with low risk, low insufflation. So this is one of the preferred modality as recommended in the literature. Third is the open cholecystectomy with open CBD exploration that has got a specific indications that I will deal in subsequent slides. Next strategy is a two-stage procedures when mostly followed when the stones are detected preoperatively. So most common procedure is a preoperative endoscopic retrograde cholangiopancreatography with the CBD clearance, followed by a laparoscopic cholecystectomy with a gap of around 12 to 24 hours. And second is the laparoscopic cholecystectomy with post-op ERCP. That has also got specific indications that I will deal with in one of my subsequent slides. Currently, there is no consensus on what simultaneous approach should be used. There are meta-analysis which I will discuss. So, when to do ERCP? When there is a clear-cut diagnosis of CBD stone either on a ultrasound or MRCP. So preoperative ERCP has to be done. But the question arises when there is a high risk or an intermediate risk of detection of CBD stones based on the risk prediction models. So it has been questioned about the patient selection, and it has been proved that it is not cost effective, and complex scoring systems have already been discussed. And previously, US and MRCP were thought to be costly and were not available, but nowadays MRCP is routinely available, so should be done as a standard of care. When doing an intraoperative ERCP, there are organizational problems regarding the concerning availability of the endoscopist in the operative room. And when we are dealing with ERCP after surgery, we have to be cautious because if the ERCP fails, then patient may require a third procedure for a completion CBD exploration. So coming on to the single stage approach, laparoscopic cholecystectomy with lap CBD exploration, it avoids the risk of sphincterotomy, and what approach has to be used, it depends upon various factors as well as the surgeon's experience. Its acceptance is far off due to steep learning curve as always, and also due to the costly instruments such as a choledocoscope, which is required for CBD clearance. This is one of the slides showing what approach has to be used for CBD exploration, whether a transcystic or a choledocotomy. To remind you that choledocoscope, smallest choledocoscope available is around 6 mm. So a cystic duct has to be around more than 4 to 5 mm for the choledocoscope to pass. Otherwise, CBD route is preferred. And if the cystic duct is located laterally or medially, posteriorly, or inferiorly, then obviously CBD route is mostly preferred. So coming on to what to do in laparoscopic CBD exploration. So there are meta-analysis which shows that primary closure is now associated with fewer complications, shorter operative time, hospital stay, and decreased cost. And it has found to be having similar mortality and similar morbidity in both the procedures. So primary choledocotomy with suture closure is nowadays preferred. T-tube has got a longer operative time and length of stay and also requires longer follow-up. It is usually preserved for some difficult cases in which there is a doubt of CBD narrowing or the difficult closure of CBD. Second is the intraoperative ERCP with laparoscopic cholecystectomy. As already told that the surgeon inserts a guide wire into the cystic duct and the endoscopist facilitates this guide wire and passed on choledocoscope or endoscope and clears the CBD and then puts in a stent into the CBD, and then a laparoscopic cholecystectomy is completed. It does not prolong the hospitalization. It has got acceptable learning curve, although it has got organizational troubles to coordinate between the endoscopists, surgeons, and OR personnel. This randomized procedure has to be shown to have overall clearance rate of around 92% and morbidity of around 3.3%. And it has shown to have operative time longer than around 14 minutes. Next is the open cholecystectomy with CBD exploration. As already told, it is limited to selected cases when there is unexpected intraoperative diagnosis of CBD stones and cholangitis with bile duct dilatation, failed ERCP with all these approaches, pre-existing open surgery or adhesions, or lack of expertise in minimally invasive surgery. Next is the two-stage. This is the most common strategy when there is a documented CBD stones, but prophylactic or based on risk certification generally usually avoided because of inherent complications. And due to two interventions, there is a risk of increased cost. Next is the post-op ERCP. Post-op ERCP is only done when there is a low risk of CBD stone and it is detected post-operatively. So when on intraoperative cholangiogram there is a small stone, then a post-operative ERCP may be planned, but additional endoloops or endoclips have to be applied on cystic duct stump, and a drain is placed usually if ERCP is planned in the post-operative period. So which approach? So there are a lot of meta-analyses which have been published. This is one of the recent meta-analyses in which I just come on to this. If you can see, the most common preferred approach is a simultaneous single-stage approach with laparoscopic cholecystectomy with intraoperative ERCP. It has got a high technical success of around 96% with a morbidity of around 18%. While we look at the other procedures, second most common preferred is lap chole with lap CBD exploration if the surgical expertise is available with a technical success of into the around 70%. So now most of the centers propose treating both gold stone and CBD stone during the same procedure. So meta-analyses have shown that single stage having superior outcome in terms of stone clearance, overall morbidity, pancreatitis, and conversion. And there is no difference in post-operative cholangitis, bleeding, or bile leak. In another meta-analysis, laparoscopic cholecystectomy with lap CBD exploration has found to be significantly lower rates of technical failure if compared over preoperative ERCP, and no difference in mortality or recurrent or retained CBD stones. Another meta-analysis also showed similar efficacies with respect to surgical success, post-operative complications, and conversion. And laparoscopic cholecystectomy with the intraoperative ERCP associated with decreased risk of retained stones, high technical success, and decreased rate of bile leak because of presence of stent inside the CBD. While the laparoscopic chole with CBD exploration has got decreased bleeding and pancreatitis. We can see with this that the hazard ratio or the odds ratio to the tune of 5.2 and 4.8 when there is intraoperative ERCP is done, but there is less bile leakage with intraoperative ERCP because of the presence of stent. So the various societies' recommendation is as recommended by these meta-analyses. First is to have an intraoperative ERCP over laparoscopic chole with lap CBD exploration, while other approaches have got weak recommendations. And so this is an algorithm that if there is a symptomatic patient with gallstone and CBD stone and intraoperative ERCP is feasible, then it should be preferred. If it is not feasible, then a laparoscopic CBD exploration should be done or a preoperative ERCP. To summarize, management depends upon the timing of CBD stone discovery, preoperative, intraoperative, and postoperative. All the five options are available when discovered preoperatively, but most common preferred and recommended in literature is laparoscopic cholecystectomy with intraoperative ERCP. Single stage lap CBD with lap chole has got similar morbidity and mortality and with similar hospital stay, so it is usually preferred by the surgeons. When CBD stones are discovered during laparoscopic cholecystectomy and are confirmed with intraoperative cholangiogram, options are laparoscopic chole with CBD exploration, intraoperative ERCP, or followed by open CBD exploration if expertise is not available, depending upon the surgical and endoscopic expertise. And if detected postoperatively, obviously ERCP is there, but it has to be kept in mind that it may be a third procedure may be required if ERCP is unable to clear the stones. So this is my last slide, that timing of how to manage the patients with CBD stones with regard to discovery of CBD stones. If diagnosed preoperatively, most common is to get a ERCP clearance followed by a lab chole with a gap of around 12 to 24 hours. That gives an idea whether the clearance is complete, whether there is no complications associated with the ERCP such as pancreatitis or bleeding, and if there is any abdominal distension due to insufflation, that also settles down over next 12 to 24 hours. So this is most common approach preferred. Next is the surgical CBD exploration with cholecystectomy, mostly laparoscopic. If detected intraoperatively, then most preferred is to do simultaneous exploration and or ERCP if expertise available. And if detected postoperatively, then ERCP or US guided clearance can be done. If fails, then one of these modalities can be adopted. Thank you.
Thank you, Peeyush. Hello.
Yeah, we have about 10 minutes, so we can have some discussion. Abhinav is going to join in about 10 minutes.
Yes.
I have a comment to make, Peeyush.
Yes, sir.
One thing that you did not talk about in your presentation is which CBD should not be explored by the average surgeon if exploration is required, and what are the complication rates in very small size CBDs, 4 to 6 millimeter size CBD, and which procedure should not be attempted in normal size CBD. That is something which should have been there on your presentation, because many surgeons, if they know that there is a CBD stone, they would like to open and remove it at surgery without appreciating that a small size CBD, when you're closing it, is likely to stricture. So
Yes, sir.
that part is something which you should put in the next presentation, wherever you make it.
Okay, sir.
Peeyush, Dr. Monica wants to know that is there any stone size limit for ERCP? I think Monica at this point, Abhinav probably will cover. He's in the endoscopist, so I think we will leave it to him. But Peeyush, I wanted to ask you, you said that most reports and reviews and meta-analysis are saying that lab chole with intra-op ERCP. But do they talk about the problem of logistics and also the positioning of the patient? So would you like to comment on that?
So most of the literature or the studies are from outside India, sir, like either from the West or the Eastern world. So mostly in these centers, the logistics or the coordination is not a problem. So mostly it is not being talked about, but I always mention in the comments or in the discussion that these are the inherent problems with having an intraoperative ERCP. So like what we follow or mostly in all the Indian centers is followed is to get a preoperative ERCP. Intraoperative ERCP is surely very difficult to coordinate with, and also it is associated with the like abdominal distension, small bowel distension, which leads to less operative space. So these are the two problems which are mainly encountered with simultaneous intraoperative ERCP.
And these reports, when they do mention lab chole with intra-op ERCP, which is done first? Is the gallbladder handled first, or are the CBD stones handled first?
It is the gallbladder that is handled first. So the surgeons handles the gallbladder, cannulates the cystic duct, passes a guide wire, which makes it easy for the endoscopist to cannulate the ampulla and then pass a cholecystoscope or an endoscope into the CBD and then do the procedure.
But the cons of this would be that if I have done the cholecystectomy and suppose the endoscopist fails to remove the CBD stone, then I need to explore the CBD laparoscopically. And because I have removed the gallbladder, I lose the retraction on the liver.
So they just do a small nick into the cystic duct. They don't divide the cystic duct. Just a nick into the cystic duct to pass into a guide wire.
Yes.
And the gallbladder is held to the liver bed for facilitating the retraction.
And I would like to repeat the point which Dr. Rajan made, and that's a very, very important point, especially if you do an intra-op cholangiogram and find small stone or stones in the CBD, which is not dilated. Unless you have the equipment, you have the skill, you have the expertise to do a transcystic CBD exploration, transcholedocal in these cases, if you make a nick in the undilated or not well dilated CBD and there are stones, the chances that you may not be able to clear, number one, and more importantly, that you may cause a CBD stricture. We have to remember that following cholecystectomy, CBD exploration is the next common cause of a bit benign biliary stricture. So undilated CBD should preferably not be explored, whether lab or open. It is best to leave these stones in situ and handle them post-operatively as early as possible endoscopically, because small stones in an undilated CBD are best suited for endoscopic management.
I want to ask a question.
Yes, please.
Dr.
Yes,
Peeyush. Regarding primary closure of CBD, is it required that the patient should be having undergone ERCP or not, or papillotomy, or the patient should not have undergone earlier ERCP? Can we use primary closure in every patient?
Yeah, Peeyush.
Yeah. I think as already highlighted by Rajan sir, that primary closure is, although preferred in literature, is reserved in cases of dilated CBD. So it is not necessary whether the patient has got a prior ERCP.
No, my question is not that. I want to ask, for example, when we do ERCP, we had they do papillotomy, so sphincter pressure are relieved, the bile flow is easy. And when we do the primary closure, the risk of leaks and blowout are less. But when we do in patients who has not undergone ERCP, the sphincter is intact. It can generate a pressure that can lead to leaks with the primary closure.
So it usually not recommended to have a prior ERCP or sphincterotomy for doing a primary closure. You have to ensure that you have
what does the literature say? So is it that primary closure should be done in every patient, irrespective of the pre-op ERCP?
Yeah. So it can be
because we have found that in those cases which there was no pre-op ERCP, the risks of CBD leaks or blowout are more in absence of ERCP, pre-op ERCP.
Younis, what you are saying what used to be said or mentioned in the textbooks, but as Peeyush has shown, the literature says that I think the only prerequisite is that you should document a CBD clearance. There should be no residual stone. So if you have cleared the CBD and if the CBD is not inflamed, friable, sutures are not cutting through, then I think the evidence says that primary closure can be done in all cases of CBD exploration, whether lab or open. Am I correct, Peeyush?
Yes, sir. Primary requisite is that the CBD should be cleared. And you always ensure either by passing an infant feeding tube or something that there is patency and either a fluid or something is going into the duodenum before doing a primary closure.
Vinay, can I make a comment here?
Yes.
A very important thing I would like to highlight here, what Dr. Vinay Kapoor said, normal size CBD for exploration, one of the least reported complications, because people don't report these things, and not that they are actually infrequent. I have seen it and I have had to manage it on table. The injury to portal vein in CBD exploration. A small diameter, thin walled CBD, in attempting to open it, the surgeon was just a little more forceful and he went through the posterior wall of CBD and slightly portal vein. The situation had to be salvaged. The consequences were not bad, but that is a real problem that can happen for an unwary surgeon. He doesn't know what this CBD diameter means. That is one thing. Second thing, documentation of completion of CBD clearance is extremely important. And for all those surgeons who want to attempt a laparoscopic CBD exploration for stone clearance, one of the most mandatory things in your armamentarium is a 6 mm cholecystoscope. If you do not have that in your armamentarium, please don't attempt laparoscopic CBD exploration. You don't know when you're going to need it. Your best efforts at milking out and with multiple CBD stones, this can be a real issue in a normal size duct. So these are dangerous pitfalls. If you are not careful about them and you are not ready, you will be caught with your pants down on the table. And you will not know how to retrieve. You convert it there and there. That's a good, safe message of getting out. But you should not attempt a lap CBD exploration if you do not have the right size cholecystoscope available to you.
Can I
So,
comment?
Yeah, Monica, please go ahead.
I'm waiting for my turn because it's very interesting discussion going on, and I fully agree with Rajan Saxena sir that normal size CBD with primary closure needed is very risky for stricture, and obviously the posteriorly portal vein is there. The cautery setting should also be adequate because it should not be higher like we use in gallbladder, but for CBD it should be a bit lower setting. Another thing is like finding stone in normal size CBD is also it's also a like is a side effect of IOC. Most probably the intra finding of the stone, if we perform elective intraoperative cholangiogram, then I think normal size CBD with some stones will be found. Although last comment to add is that even the normal size CBD are very risky for creation of pancreatitis in ERCP. So in all modalities of CBD stone treatment, be it endoscopic, be it laparoscopic, or be it open, the normal size or a lower size CBD is the risk factor.
So, Peeyush, going back to a pre-operatively detected CBD stone, either on MRCP, either on ultrasound, MRCP, or endoscopic ultrasound, you said that three options: lab chole with pre-op endoscopic clearance followed by lab chole and simultaneous lab CBD exploration, and lab chole with intra-op ERCP. Now, at least for our country, most centers, including some premier institutions, the third option seems to be logistically very difficult. So let us keep that out for the time being. We have basically two options: pre-op endoscopic clearance followed by lab chole, and lab chole and lab CBD exploration. So one very crude parameter which I use is I look at the number of stones in the CBD. If they are countable stones, if on the cholangiogram, whether MRCP or whatever, I can count the stones, then I am more inclined to suggest that yes, you can do lab chole and lab CBD exploration with all the points which Dr. Rajan mentioned, that you should have the expertise, you should have the skill, you should have the equipment to demonstrate CBD clearance. On the other hand, if it is an undilated CBD with multiple small non-countable, why I said countable? Because if I know that there are 3 stones in CBD and I have taken out 3 stones during the lab CBD exploration, I know that I have cleared all of them. But if there are multiple stones, I don't know. Then it is absolutely mandatory to have a post-exploratory cholangiogram or choledocoscopy to demonstrate that CBD is clear and then handle it. So that could be one crude kind of a method to decide the CBD diameter and number of stones and size of stones, which one can use to decide whether pre-op clearance. It would be worth, actually, one of the young faculty members like you or Younis should do a questionnaire survey that irrespective of what the literature says, what are the practices in India? What do most surgeons do or most gastroenterologists do when they see a patient with a pre-operatively diagnosed gallstone and CBD stone? My hunch is that most of the surgeons today would go for a pre-op ERCP endoscopic clearance followed by lab chole, except a very few who are hardcore so-called minimally invasive surgeons who would say that we will do a lab chole and lab CBD explosion. It would be worth doing that and getting the opinion of people as to for what reason they choose one or the other. So I see that Abhinav has joined. So Abhinav is again a product of SGPGI. He did his DM from SGPGI and he is now one of the leading gastroenterologists attached to the CK Birla Hospital in Jaipur. Abhinav has been on the faculty of the previous master classes also. And I must say that whenever I request him to chip in for non-surgical, endoscopic or gastroenterological topics, he never says no to me. I don't know whether it is because I ask him, but I presume it is because of his interest in teaching still, although he is working in a corporate hospital. Welcome back, Abhinav, and thank you very much.
Thanks for the kind introduction, sir. I won't waste a second. Straightway come to the topic which is given to me: endoscopic treatment of CBD stone. Now, these are the guidelines I'll be following because these are the latest available guidelines which everybody is following, and they are good guidelines because they guide on practical aspects of CBD stone management as far as endoscopy is concerned. So as we all know that approximately 1/5 of all symptomatic gallstone taken for cholecystectomy might be having CBD stone. It leads to complications which are deadly like cholangitis, pancreatitis. And ERCP is modality of treatment choice for the treatment of CBD stone as it is minimally invasive. But the problem is adverse event which can go up to 15% in some cases. So the kind of serious adverse event the ERCP might lead to has dictated that we should be saying no to diagnostic ERCP, and with the MRCP and EUS, almost it has been eliminated. Now these are the old recommendation. Since we have to choose our patient very wisely, whether a patient is having CBD stone concomitant with gallstone or not. So our suspicion has to be strong on the basis of these parameters. And earlier in these guidelines, which were brought in somewhere around 2010, bilirubin and dilated CBD were being taken separately. Bilirubin more than 4 or dilated CBD more than 6 millimeter to make a suspicion of CBD stone. Other than direct evidence like stone seen on a transabdominal ultrasound or ascending cholangitis. But guidelines have subsequently been revised because these guidelines led to unnecessary ERCPs and negative ERCPs. So now guidelines are for prediction of choledocholithiasis are, other than if you see direct CBD stone on ultrasound or cross-sectional imaging, or if you're ascending cholangitis, other than that, the area of confusion has been obviated, which is they have combined total bilirubin more than 4 and dilated CBD. So they have to be together to make a suspicion of CBD stone. And if these things are there, then we can directly proceed to ERCP. And in absence of these findings, we have to first confirm presence of CBD stone with cross-sectional imaging. So nowadays for diagnosis, ERCP, big no, we can go ahead with the endoscopic ultrasound or MRCP. Well, as far as EUS is concerned, EUS is comparable to MRCP. As far as diagnosis CBD stone is concerned, and specifically it is more sensitive for stone more than 5 millimeter, for microliths or sludge, or for stone impacted a temple. I'll take a second. I'll take a second. Yeah. Sorry for that. So for smaller stone, for microliths or sludge, or for impacted stone at ampulla, EUS is more sensitive. And then there are certain situations where we prefer EUS over MRCP, as in case of claustrophobic patient or pacemaker. But if altered anatomy is there, like gastrointestinal bypass has been made, then MRCP is preferred. Coming to my topic, ERCP. For stone removal, 90% of the simple stone can be easily removed with ERCP. There are only 10% difficult stone which cannot be removed. And when stones are there, and especially multiple or large stones are there, 25% of the patient might require subsequent ERCP procedures. But majority, more than 75% CBD can be cleared in one ERCP procedure only. Now, to diagnose CBD stone, whether we should go for ERCP or imaging. So latest AG guideline 2019, they have clarified issue with almost certainty. If suspicion is high, that is if CBD stone is seen on imaging, or if there is cholangitis or bilirubin more than 4 in conjunction with dilated CBD, then chances of CBD stone are very high, more than 50%. And next step would be ERCP. And in absence of this, if only abnormal LFT are there, if age is more than 55 or dilated CBD, then we have to first confirm presence of CBD stone with EUS, MRCP, or intraoperative modalities like intraoperative cholangiogram or intraoperative ultrasound. If none of the above, then directly go for cholecystectomy. So for these were as far as symptomatic gallstones were concerned. But for asymptomatic also, CBD stone clearance with ERCP has been recommended even in asymptomatic stone, since we do not know the natural history of untreated CBD stones. The problem is ERCP-related complication, which is more in asymptomatic cases. In symptomatic, we have seen that highest frequency of complication 15%, but in asymptomatic CBD stones, the complication rate may go up to 25%. But still, all of the guidelines, since we do not know the natural history of these asymptomatic CBD stones, so all of the guidelines, they recommend ERCP to remove the stone. But only thing we have to be careful about complication, and these asymptomatic patients specifically have to be done by expert and at a high volume sample. Now, a specific situation like gallstone pancreatitis, whether we should do early ERCP or late ERCP, this is the meta-analysis, 7 randomized control trial, more than 750 patients. This is available in Cochrane library. So, early ERCP, mortality, local complication, and systemic complication, related risk is high. So, urgent ERCP should only be done if cholangitis is there or persistent biliary obstruction there. Otherwise, ERCP in cases of gallstone pancreatitis should be delayed for more than 48 hours till pancreas is cooled off. Sometimes in the gallstone pancreatitis, we have simple situation like stone obstructing papilla, it bulges papillary orifice, and we just have to give a nick and stone pops out, job is done. Now, timing for ERCP for cholangitis. Cholangitis, as we know, that this is a dreaded complication of obstructed biliary system. So this meta-analysis studied nine studies and 7,500 patients. Emergent ERCP, that is ERCP within 48 hours versus delayed ERCP. And they saw that if ERCP is done within 48 hours, there is lower risk of organ failure, lower mortality, and shorter hospital stay. So in cases of cholangitis, urgent ERCP within 48 hours. In presence of pancreatitis, delayed ERCP after 48 hours. So guidelines are clear now on this. Now, what is the algorithm we routinely follow for treatment of endoscopic treatment of CBD? If a small stone are there is no stricture, then simply sphincterotomy and balloon or basket extraction. If stone is slightly bigger, then limited sphincterotomy with balloon dilatation and job is done. For large stone, dilated distal CBD, large balloon dilatation is done. For large stone, but distal CBD is smaller than a stone, then we have to resort to other modalities. Now, coming to the first situation, small stone, no stricture. ERCP, sphincterotomy, balloon shift, 90% success rate. So this is the easiest subset of the patient. Even if multiple stones are there, no problem, they can be cleared one by one. And in situation where even CBD is totally jammed up, impacted, even then, even with small sphincterotomy, all of the stone can be removed. Now, second situation, large stone with dilated CBD. Here we need to resort to large balloon dilatation since the stone is larger. So strategies for these large stones is either we can enlarge the CBD stone either with the sphincterotomy or balloon sphincteroplasty, or we can reduce the stone size by crushing, or we can combine both of the approaches. Now, liberal sphincterotomy to enlarge the opening of the CBD. The problem is this is limited by the safe portion of the papilla. Means how much portion of papilla is there in the intraduodenal wall. So if we are lucky, if we get a large intraduodenal portion like this case, we can remove a bigger stone simply with liberal sphincterotomy, but we have to be cautious. Sometimes this may lead to perforation. So careful assessment of papilla is must. Second option to enlarge CBD opening is balloon sphincteroplasty. So here we can put in a balloon at the sphincter and then we can dilate. There have been studied with simply only with balloon dilatation without sphincterotomy, but it was seen that there were cases of pancreatitis and some of those cases were fatal. So nowadays, small sphincterotomy is done followed by balloon dilatation. What sphincterotomy does, it provides a pathway for balloon to expand, and this pathway takes the pressure away from the pancreas, so pancreatitis doesn't occur. So balloon sphincteroplasty followed by balloon dilatation, small sphincterotomy with the balloon dilatation is the way to go. Now, these are the results. Comparison of balloon sphincteroplasty versus EST, yani sphincterotomy alone. So balloon sphincteroplasty, if combined with EST, it leads to overall increase in clearance of CBD stone. It obvious need of mechanical lithotripsy, and it also reduces adverse event. So whenever there is a large stone, we should do small sphincterotomy with balloon sphincteroplasty rather than sphincterotomy alone, since combination is better in terms of all these parameters. Now, again, very large stone, but CBD is not strictured. This is the example how balloon sphincteroplasty is done after small sphincterotomy. We can see that on subsequent cholangiogram, CBD is clear and stone can be removed. Even if CBD is packed with a stone, including one of few stones which are larger one, this technique helps. We can clear CBD completely.
Ground floor emergency bed number 8402.
Even gigantic stones like this can be removed using
bed number 8402.
So even larger stone like this can be removed using this technique, small sphincterotomy and large balloon sphincteroplasty. Again, we have to see that doing large balloon sphincteroplasty can sometimes lead to more of bleed and sometimes perforation risk is there. So with all these techniques, sphincteroplasty, sphincterotomy, dilatation of bile duct, should we redefine the common bile duct stone? Earlier, more than 1 centimeter stones used to be considered as a very large stone, but nowadays, utilizing these techniques, we can remove even a stone up to 2 centimeters very easily without without need of any further equipments. So there is a need to redefine large stone. The problem comes when stone is large, but lower CBD is smaller than the size of the stone. In these cases, we need to go further. We need either cholangioscopy or we need mechanical lithotripsy kind of equipments. So before embarking on this, we should understand what is a difficult stone. Difficult stone can be because of characteristics of stone. It can be because of lower CBD parameters and other things. So if a stone is very large, we don't know the size. Some literature says it is more than 1.5 centimeters, some say 2, some say 3 centimeters. But in general, usually 2 to 2.5 centimeter stone is considered large one. Sometimes even a smaller stone as small as 8 millimeter can also be a large stone if it is large enough for lower CBD. Shape of stone is also to be taken in consideration. Certain shapes like barrel or piston shapes are difficult to remove. A very hard stone again is difficult to remove. If lower CBD is narrow, small papilla is small. If lower CBD shape is abnormal like sigmoid shape, if there is large periampular diverticulum, then this make a stone difficult to be removed. Faceted stone, impacted stone, intrahepatic stone, and altered biliary anatomy, they lead to difficulty in stone removal. So we have to consider all these parameters before attempting biliary stone removal. See this cholangiogram, stone is quite big and lower CBD is absolutely narrow. So this stone cannot be removed without any additional procedures. Sometimes, if such a situation arises, we may just put in a stent and we come out, because putting in a stent and going subsequent occasion after 4 weeks, due to constant friction of a stent, stone becomes softer, and sometimes it may get fragmented. And second time ERCP, we might remove it very easily. Sometimes lower CBD is very narrow. Here, stone is hidden behind the endoscope. It cannot be seen. It is small stone, but lower CBD is very narrow. Wise decision to put in a stent and come out. On subsequent visits, we can see that this is a second ERCP. As we can see, a stent is there on left side of the panel. The cholangiogram shows very large gigantic stone. Biliary balloon dilatation is being done, and the stone can be removed on subsequent attempt. So the caveat is that if stone is very big, if it cannot be removed in one ERCP, so once two short ERCPs are better than one long ERCP, which would, because longer the procedure do, higher the chances of perforation and higher the chances of complications. Now coming to next step, mechanical lithotripsy. So in situation with this, where stone is very large and lower CBD is narrow, we have to resort to mechanical lithotripsy. Two varieties are available. One is through the scope lithotripters, where there is a metal sheath and basket which you can insert through the scope without need to remove the scope. And other are out of the scope lithotripters, which are available in the market. Now, success rate of these techniques is 79 to 90% after failed conventional method, which is biliary balloon sphincteroplasty for removal of large stone. Now, this is the most dreaded situation for a gastroenterologist doing intervention. You see there is a basket and no endoscope. Means basket has infected and endoscope has been removed. What to do now? Either you go for surgery or you utilize some kind of lithotripsy techniques, which is out of the scope lithotripsy. So out of the scope lithotripsy, also called mechanical rescue mechanical lithotripsy. Here we have to cut the basket which is hanging out of the scope because other end is stuck up in the CBD. We cut the basket, we remove the endoscope, and we load these wires into the coil sheath of the lithotripter metallic coil. And then we pass wire into the handle. And as we rotate the handle, it crushes the stone inside the CBD. Now, this is a short video how this mechanism works. If somebody gets stuck up with the impacted basket, they can cut the wire and they can break the stone using this lithotripter out of the scope lithotripter. The only thing you have to sacrifice your basket here. And some of the basket, they do not, sometimes the stone is very hard. So even basket breaks, but that is again okay. At least you are able to disinfect the basket. Yeah. Now, this is the example of through the scope mechanical lithotripsy. You can see in lower left panel, a metal sheath is being advanced through the endoscope, and we can see the stones are being crushed and stone can be taken out using this technique. So for difficult stone, initially we would try with balloon or basket after biliary sphincteroplasty. If there is a failure, we try mechanical lithotripsy. But even if mechanical lithotripsy fails, then we have cholangioscopy guide option. So these are the options for failed mechanical lithotripsy. You can use cholangioscope. Two options are there: laser lithotripsy or electrohydrolithotripsy. There is an option of extracorporeal shockwave lithotripsy. Patient can be sent for surgery, or you can just put in a stent and do the procedure on subsequent visit. So what is the how extracorporeal shockwave lithotripsy this helps? Basically, we have to focus shockwaves on calculi, and shockwave, they basically generate energy in the stone, and stone get blasted. Complete dedicated setup have to be there. And one requirement which is very essential, since all of the 90% of CBD stones are not radio opaque, there is a need to put in a nasobiliary catheter. We pass contrast to the catheter to opacify the stone, and then only we can focus the scope. We can focus the stone and break them in shockwave. Complete clearance rate to the tune of 85%, and 2/3 of the patient, they require 3 or more sessions of lithotripsy to break the stone, to pulverize the stone. Now, ESW is not free from adverse effect. There are a lot of adverse effects. That is why this technique is not very popular as far as CBD stones are concerned. Subcutaneous ecchymosis, bleeding complications, cholangitis, pancreatitis, sometimes bowel perforation, even lung perforation, splenic trauma, and cardiac arrhythmia. These side effects, when they happen, they are very serious. So this is not very popular method in most of the center, barring a few. Intraductal lithotripsy is catching up. Cholangioscope, it is different equipment. You can pass this equipment through the biopsy channel of the scope. You can directly peep into the CBD. You can pass laser fibers. You can pass electrohydrophilic equipments, and you can pulverize the infected stones. And these are the trials. All of these trials on the criteria of selection were the number of patients should be more than 10. And you can see the results vary from 72% in earlier series to 90 to 100% success in the series which were published 2005 and onwards. Now, intraductal therapy versus conventional therapy. If conventional therapy is compared with intraductal therapy like cholecystoscopic guided, then cholecystoscopic guided techniques they are way better. But if conventional techniques are combined with biliary balloon sphincteroplasty, then results are almost similar. So we can, if we have to resort to these techniques only with when conventional therapy with biliary balloon dilatation fails, then we can go ahead with cholecystoscopic guided techniques. Now, for difficult biliary stone, this is a comprehensive review of new and old lithotripsy technique. And last two columns which I have highlighted, they are important because these two studies pertain to utilization of these technique in failed conventional therapy using sphincterotomy and biliary balloon sphincteroplasty. So when after failed conventional method, cholecystoscopic technique versus mechanical lithotripsy, you can see in both of these studies, cholecystoscopic technique have better success rate than mechanical lithotripsy. 100% versus 63%, 93% versus 72%. So after failed conventional method, preference would be to go ahead with cholecystoscopic technique available, especially after failed mechanical lithotripsy. So cholecystoscopic techniques are very good. Now, failed stone extraction. We should also look outside CBD what is happening. Like this, and other causes. Like in this case, this is a pseudo calculus. This is not a true calculus. This filling defect is because of inspissated bile, which is stuck upon CBD wall, and this will give a filling defect. Whatever balloon sweep you do, you will not be able to remove it. Sometimes cystic duct stone overlaps with CBD and looks like that this is a CBD stone, difficult one. Whatever balloon sweep you do, this stone cannot be catch up. And if you rotate your C-arm, then you can see that this is a cystic duct rather than CBD. So this is also to be taken in. With failed extraction, this is one of my cases. This lady had 2 ERCPs. Both time failed extraction. You can see a stent is there, which looks like very old stent. And when we did cholangiogram, it looks like that CBD is grossly dilated and there is large stone and narrow CBD down there. But if you look at this cholangiogram very carefully, you can see that the structure on left is cystic duct rather than CBD, and the stone is lying in cystic duct, which is very low cystic insertion. So this is a case of Mirizzi syndrome rather than CBD stone. So correct identification and correct high index of suspicion is needed because in these cases, the stone will not be removed with usual methods. And we should also be aware of unusual findings. Sometimes we just keep on focusing on CBD stone and we may miss something very important. Like this case, last week only I have done this case. This patient presented with obstructive jaundice of 20 days and mild pain. Cholangiogram revealed nothing remarkable. Complete cholangiogram, we did complete cholangiogram. Then upper part of CBD is not very well visualized. We did a small sphincterotomy, balloon sweep. We removed some of the stones, but we were not convinced with upper part of CBD because this is not filling up. Even when we put in a balloon and did occlusion cholangiogram, upper CBD didn't fill up. So probably there is a stricture. Then we took him for, in the same sitting, we took him for EUS. In EUS, we could see sludge in gallbladder, and you can see nice gallbladder neck with pharyngine cap-like of structure, but there is nothing there. And there was small round lymph node at porta. So if lymph node is oblong, then it is okay. Round lymph nodes are not good as EUS data say. So we did FN up this lymph node, and it to our surprise it was adenocarcinoma. So probably this is a case of cholangiocarcinoma with CBD stone, and we should not miss these cases, and we should not sit quietly after removing the stone. Index should be. So these are my summary points. CBD stone, we do ERCP only if a stone are seen on imaging, if there is cholangitis, or if there is high bilirubin more than 4, along with dilated CBD. These are the criteria, ANU, AG criteria. In other cases, we go for MRCP EUS to confirm the presence of CBD stone first, and then we intervene. For gallstone pancreatitis, ERCP, once pancreas cooled off, that is after 48 hours, we don't do ERCP in hot pancreas since it leads to complication and mortality. In cholangitis, we tend to do early ERCP within 48 hours, but if patient is very sick in septic shock, then we have to stabilize him first and then early cholangitis. Small stone, normal CBD, no problem, that will be removed simply with sphincterotomy. Large stone, normal CBD, sphincterotomy with balloon sphincteroplasty will serve the job. Large stone with narrow CBD, it is a problematic situation. We have to resort to mechanical lithotripsy, impacted stone, failed mechanical lithotripsy, spyglass cholangiography endoscopic guided treatment. And with all these modality, this is the last algorithm I would leave you with. Need for surgery for the CBD stone per se, need has been reduced drastically, and most of the times stone can be removed with endoscopic. Thank you so much.
Dr. Rajan, there are some questions which I put in the chat box. You can maybe target those questions to individual panelists and seek the answer from them.
Before I go on to the questions, I have a few things to ask from Dr. Abhinav.
Yes,
sir.
please.
Abhinav, excellent presentation.
Thank you, sir.
Thank you. Illustrative and very informative.
Yes.
And from this, I got an inspiration to ask you a few questions.
Yes, sir. Yes, sir.
In
Abhinav, it's flattering that
yes,
Dr. Rajan is getting inspiration from you.
Yes, sir. He has been inspiration for all of us, sir.
Yeah, please go ahead, Dr.
In 1989, at STPGI only, there was a CBD stone extraction attempted.
Yes, sir.
The Dornier basket got locked inside.
Yes, sir.
It could not be moved out, and
Yes,
Dr. Chaudhary was not willing to sacrifice the stone holding basket.
Yes, sir.
And then he was stuck, nothing to do. We were called in. We were operating in the OT. We were called in. What can be done in this situation? I said, just cut the wire.
Yes, sir.
And remove your scope.
Yes, sir.
He said, what will happen after that? I said, over to the first floor. We
Yes,
used to operate in the neurosurgical theater, now present neurosurgical theater. So very reluctantly he agreed. But that was an important thing to learn was that the stone with the wire or mesh on top of that was impacted in such a way that even at open CBD exploration, it was not easy to remove that.
Yes, sir.
Because it tends to get locked in somewhere and a bit of tissue comes in the wire. And then you have had it. You can't move the stone anyway.
Yes, sir.
That was one experience that was worth, and you demonstrated very rightly, strong mechanical lithotripsy to the wire can possibly solve the situation. At that time, these lithotripsies were not available.
Yes, sir.
Now, the second thing which I have to ask you is about the lithotripsy used on CBD stones.
Yes,
large stones being managed by ESWL particularly. The ESWL, do you have any information or are you aware of any study which gives a long-term follow-up of CBD treated by ESWL for large stones? There was a
studies are there. One of the studies from AIG only, Dr. Manu Tandon's study, I think in 1991 or 2011, I'm forgetting. But the long-term follow-up with the ESWL treated patient, there is high recurrence CBD stone. So that is the problem there.
No, recurrent CBD stone is not the issue. How does the CBD behave? I'll tell you the operative findings of patients who have been treated by ESWL. When you go and operate on these patients, again, they were stuck stones. So when you open, the CBD is sputtered with multiple punctate hemorrhages.
Yes, sir. Inflammation, it leads to cholangitis and inflammation of CBD.
And so what is next? On opening the CBD,
yes, sir,
the entire mucosal cylinder of the CBD came out as a cast.
Yes, sir.
Now, this is a CBD which is bereft of mucosa.
Yes, sir.
We managed to close it. We put in a T-tube, and after that, remove the T-tube after 3 weeks. but I could not follow up this patient for more than 4 years.
Yes,
She was not to follow up. Are you aware of any study which has looked selectively at the behavior of CBDs on long-term basis after ESWL?
so formation of stricture and all those complications will take very long time. I'm not aware that if somebody has followed them up for that long. And
Okay.
Of late, people have stopped doing
Yes.
corporal lithotripsy because of these complications only.
No, these will be available only from older patients, 90s, 80s and 90s.
I'm not aware, sir.
Not aware. Okay. Good presentation. I must compliment you for that. Very informative lecture.
Thank you, sir. Thank you.
Yeah,
Now
Dr.
we
Rajan,
come on
please.
to the
Yeah, the chat
points which have been
questions.
said. Monica Gupta's first question you've already answered. Stone size limit for ERCP, Abhinav has
Yeah,
answered.
but still, Monica's question, Abhinav, a direct question that
Yes, sir.
do you say no to endoscopic management based on the size of the stone?
Sir, 3 centimeter stone is a very difficult one, particularly if it snugly fits CBD, because in these cases, usually even basket doesn't go across. Even if we are able to somehow manage a basket across, it will not open up, and all of the wires are not able to trap the basket, trap the stone. So these are the cases where straightway saying no is better than struggling in the ERCP. Because
But
once we put in the
what about lithotripsy?
Sir, if cholangioscopy guided lithotripsy is available, then it can be done. Mechanical lithotripsy is usually not successful in these cases.
So for the students, the answer is that if the stone is too big, and Dr. Abhinav says 3 centimeter, then if you have a cholangioscopic lithotripter, which will be a laser lithotripter, isn't it?
Yes, sir.
Yes.
Then you have an option. But mechanical lithotripter for a 3 centimeter stone would be no for most endoscopists.
Abhinav, there is one more question for you.
Yes, sir.
What is the incidence of CBD perforation following cholangioscopic laser lithotripsy?
Sir, cholangioscopy is very safe because the laser doesn't fire on soft tissue. So
Contact laser.
it's very safe. It's very safe. But yes, with mechanical, sometimes basket might go across. So mechanical is sometimes very dangerous. If there is lot of resistance, we should not pursue much, and we should not try to pass stone basket across it.
Yeah, Dr. Rajan, you can address the rest of the questions to the individual panelists, please.
Again, this is a question to Abhinav from Senegal. Impaction of a stone in the distal part of CBD. Some difficulties to remove the stone may expose to a spasm of the sphincter of body and probably a biliary fistula. Why? I'm not able to understand the question.
Biliary fistula.
Yeah, how will a biliary fistula form in this session? If not damage the CBD.
I don't understand the question, sir, exactly.
Yeah, even I can't understand. The second question was, do you think that a T-tube should be routine in this case? Which case?
I think Peeyush can take that.
No, T-tube is not. Peeyush can take that, yeah.
I think Dr. Guy Limbe wants to know that if there is an impacted stone, Peeyush, would you take that?
I'm not able to understand the question.
He says that there is a stone impacted in the distal end of the CBD, and there is a difficulty in removing the stone. So this may cause the spasm of the sphincter of Oddi. So even if you have cleared the CBD, in a case like this, where you have done a lot of manipulation at the lower end, which may be inducing a spasm of the sphincter, would you then place a CBD T-tube rather than do a primary closure? I think that's what Dr. Guy Limbe wants to know.
I think, sir, if nowadays the recommendation is that if you are able to ensure and document that the CBD clearance is complete, then I think T-tube is not recommended.
Not be.
Most importantly, for putting in a T-tube, nowadays the T-tube has become so obsolete that you should have it before the procedure. Otherwise, you don't get a T-tube so easily nowadays, especially for those smaller size T-tubes.
Sir, stones in lower part of CBD is now usually not big. Usually these are small stones which get impacted in lower CBD, and usually we are able to manipulate wire across. So this situation, whether it's biliary spasm, sphincter body spasm is there or not, we can go ahead and cut the sphincter, do small sphincterotomy, and we can pass in the pass across his stent. And on second ERCP, I think this stone can be removed very easily.
So an impacted stone is not a problem for the endoscopist, because the moment they do the papillotomy on the stone gets exposed. It is a problem for us. So
Yes.
that is why if it is a small stone and it looks as if it is impacted at lower end, as Dr. Abhinav says, endoscopic is probably a better option. But Dr. Guy probably is hinting that at surgery, if we find an impacted stone, a lot of manipulation is done. So he is worried about the sphincter spasm. Yeah, we can take the next question then.
Yeah, can I come in between?
Yes, please.
Yeah. There are two important things about impacted stones. The nature of impaction just above the ampulla, very easy for the endoscopist to manage. Peeyush showed, make a sphincterotomy and the stone pops out. Now, there is one situation where a chronic CBD stone forms a shelf in the lower CBD and impacts on that. That I have found endoscopists impossible to retrieve.
Agreed.
They are not able to negotiate beyond. And
So-
even at surgery, transcolidocal, we were trying to remove it and we were unable to do it. The last resort was cauterizing the duodenum, going behind and making a direct incision on the lower CBD and popping it out. It can be a very, very difficult situation, even at open surgery. If there's a shelf forming there, long-standing impaction of CBD stone, it can be a hell for the surgeon and the endoscopist both.
No,
That
but Abhinav, Abhinav, suppose there is a stone impacted at the lower end. You can't pass a guide wire along with it because it is tightly fitting, but you can always open the papilla on the stone.
Yes, sir. Yes, that actually I showed in the
You showed
slide.
that picture also.
Yeah. So that
Would
is
you like to show? Would you like? I'll stop sharing. Maybe you
Yes.
can share and show that. So that is the point I was saying, that for an expert endoscopist, an impacted stone should not be a problem.
And I think,
Because
sir, nowadays
we
even
didn't
that-
touch on that, Peeyush. Would you say that today, with all these expert endoscopists around, is there any place of a transduodenal sphincteroplasty to take out an impacted stone?
I don't think so, sir. I was amazed to see
that's
a
what.
slide, sir, where there was not even a single indication for surgery for CBD stones less than 3 centimeter.
Oh, okay. Hold on. I'll come on to that. But before that, I want to make a comment on Peeyush. Peeyush,
Yes,
your
sir.
statement about P-tube becoming obsolete.
Yes, sir.
I would advise you to refrain from using these terms. Surgical literature has a lot of lessons to learn from if you have read the past. How things have evolved and come to a present stage. What is difficult today to get is number 10 T-tube. Most
Yes.
people don't stock it. So if it's a normal size CBD that you're dealing with, then possibly you will be in trouble in trying to secure it. And then the best way out there is put a double pigtail stent
Yes, sir.
and throw the CBD over
I
that.
agree.
Right?
Yeah, I agree that stent is a better option.
It's a better
Because
option. In a thin
T-tubes
wall,
are-
small size CBD, that's a better option to use.
Definitely, sir.
And you have to make sure that the stent has
gone.
gone across the papilla into the duodenum. Yeah, Abhinav, please explain this.
So this is the case, sir. Biliary acute pancreatitis. We can see on the first panel, right left upper corner. You can see bulging papilla. This is typical appearance when stone is right at the orifice, because of constant bile flow and pancreatic juice flow, the papilla swells up and it bulges into the lumen of the duodenum. We just need to put in a nick over the mucosa and sphincter orifice, and stone pops out. This is the situation one. The second situation which Dr. Rajan is referring to is stone impacted not at the papilla, but in the lower CBD, just within 1 to 2 centimeter papilla, forming a small diverticulum there. That is a very difficult situation for even endoscopists, because balloon and basket slips out. In lower CBD, we need some space for cholangioscope to insert. So that is a very difficult situation.
So this question number 5, Vinay Timilsina, that what is the management of impacted distal CBD stone despite 2 or 3 RCP sessions? I think that would be a very, very rare situation today, isn't it?
Yes, sir. Yes, sir.
Vinay, this other question we are going to handle tomorrow when we are going to discuss the CBD drainage procedure. So I think I will leave it at that. I had a question to Abhinav,
Yes.
and then Peeyush can also answer that. That you have gallstones and CBD stones. We have decided for a pre-operative ERCP endoscopic clearance and followed by lap chole. You have documented that CBD is clear. Would you leave a stent or would you not leave a stent?
If ERC, that depends on multiple factors. Sir. Number one, where patient is coming from and where patient will go for is lap chole. Suppose he is going outstation, मैं अपने native place में lap chole कराऊंगा. In that case, we'll always put in a stent. If cystic duct is very wide on endoscopy, and indirectly we can also assess by the number of stone and the size of stone. If multiple small stones are filling up the CBD, then probably cystic duct is wide. I would like to put in a stent. But if it is a very small stone, single stone, narrow cystic duct, lap chole is being planned in the same city on the very next day, then I would not put in a stent.
Peeyush, as a surgeon,
Yes, sir. I like to make a comment.
sorry. As
Yes,
a
sir.
surgeon, if the endoscopist has cleared the CBD and you are going to operate the same day or next day, would you prefer to have a stent or would you not like to have a stent?
Yes, sir. I like to make a comment. This is always a debate we are going on between us and our gastroenterologist. As already told by sir that they are not in favor of putting in a stent. But as a surgeon, I would like to have a stent placed because even if we do within 12 hours or within 24 hours, there is a lot of inflammation in the porta and around the Calais triangle. So it is always safe to have a stent inside the CBD when we are dissecting around that area, and we can easily clip the cystic duct because we have a stent in situ, and also it helps in easier identification. So I think it is, as a surgeon, I would like to have a stent placed because removal of a stent just hardly takes an endoscope to remove after 4 to 6 weeks.
But I would caution the students that if you are doing a lap chole in a patient who has a stent in situ, for patient's sake, please tell the patient, tell the relatives, make sure get an appointment with your gastroenterologist to get the stent removed. And for your own sake, please document in the discharge summary advised stent removal. All of us have seen stents lying in the CBD for months and sometimes even years, and that would amount to negligence. So for patient's sake, as well as for your sake, tell the patient and document it.
Vinay, I have removed a stent today after 19 years.
We also have Dr. Iqbal Salim, who's going to join us tomorrow. But Dr. Iqbal, we would love to have any comments from you. Monica is also there. Monica, please feel free to chip in. Saurabh, are you there? Saurabh Galoda? Saurabh had sent a comment that he had done some study on pre-op ERCP.
Yes, sir.
Yeah, please. So Saurabh, can you give a brief summary of the study which you were referring to on the chat? Please come in.
Yes, sir.
So
Sir,
Saurabh
actually,
again is a former fellow from SGPGI. He is currently at AIIMS, New Delhi. Yes, Saurabh.
sir, actually, when I was in Himachal, that is about 2-3 years back, we had given a study to one of our PG there, where actually we did a sequential ERCP. That is because the ERCP was actually being done in the same OT that we used to do, like another OT. So what we used to do is we used to do in those patients, we selected the patients in which we were sure that the clearance was done. So we included 63 patients and we had 3 groups. One group was in which a sequential ERCP was done. That is within the first 6 hours we used to do, like after they have done an ERCP and patient is out there, and there is a complete clearance of stones. So we did a lap chole in those patients after this. And second patients were in which within 72 hours we used to do a laparoscopic cholecystectomy. And the third was the classical one where actually we used to wait for 6 weeks post ERCP to do a lap cholecystectomy. And we found that if we are able to, so the problems with the sequential ERCP, which was the most common, was that there will be a lot of bowel distension. Because obviously you are using some amount of gas also, and so distension of the bowel. And so actually we faced in the total 21 patients each. Out of this, in group B, where we were actually doing 72 hours, within 72 hours, 2 patients developed pancreatitis. So they shifted to the delayed phase, that is after 6 weeks. But when we compared what parameters we compared was operative time, bleeding, bile leak, and then finally hospital stay. and we found that the sequential ERCP has the only issue that if we were able to, like initial patients, we had this problem of abdominal distension, the bowel distension, how we had to cope with it. But then we found that we talked to our ERCP guys, friends, and they would do suction, and we were able to do the surgery in all patients. 3 patients we converted to open, but out of those, only 1 was due to bowel distension, while 2 were actually because of clear Callet's anatomy at that point in time. So total, if we compared these modifications, and even the hospital stay was also least in the sequential ERCP. The good point for us was that because we were doing in the same OT suite, so we did not have a problem of shifting the patient to some other place and all that. So that was an advantage to us. Probably that is one of the reasons why we did not have the logistical issues that usually we face with a sequential ERCP. But we found that if we are able to do in the same sitting after the ERCP, we can do a pre-op ERCP and then follow it up with a lap cholecystectomy. We need not wait for even for 24 to 48 hours that we usually do.
Yeah, so basic issue is the logistics.
The issues that to cover those logistics, we found that we actually presented it last year in the ACS annual congress in Boston. One of the MBBS fellows actually presented it. I didn't go, but somebody else went and presented it, and it was very well received actually there. And they said that yes, it is because actually there were also many centers there also are following the sequential ERCP.
So another question I would like Peeyush to
That
answer,
was-
and then Dr. Rajan to comment that when do you operate after the CBD has been cleared endoscopically? Same day, next day, or wait? Peeyush first, and then Dr. Rajan's comment.
Yes, sir. So before I think answering this question, I'd like to make a comment upon Saurabh sir's. I think what I already discussed or showed in my slides also, that best is the intraoperative ERCP. So like if we do simultaneously with lap chole, when the cystic duct is cannulated and we have the access to the CBD. So there is no problem in dissecting the Callet's after the bowel distension. So then it is easier, and technical success is also more that has been shown. Regarding the question, sir, I think as far as we practice, because of our logistical issue, and at least we wait for almost 18 to 24 hours after having an ERCP.
So which means the next day.
Next day. Because it gives a
suppose logistics are not an issue, scientifically speaking, would you do it the same day or the next day?
So I would like to wait for at least 12 hours because it gives.
Tell the reason for the students.
Yes, sir. So waiting gives an idea whether the ERCP procedure was smooth, patient has not developed any complications related to that procedure that may affect your another procedure. So waiting for 12 to 24 hours is a safer option. And also the bowel distension caused by ERCP will settle down in that period. So doing a laparoscopic surgery will also become easier in a gap of such period, sir.
Dr. Rajan, your comment on this?
2 comments, Vinay. If you do the surgery within the 24 hours period after ERCP, these patients resume oral feeding much later. They are not comfortable after laparoscopic cholecystectomy the way a normal patient is. And this is my observation. I have actually now taken on a policy. I would not do cholecystectomy on the same day or the next day. I wait for 48 hours. I have seen 2 cases of pancreatitis manifesting 24 hours later. The amylase was elevated, but clinically the patient was fine. And 24 hours later, the patient was miserable. So problem of ERCP, most would manifest on the same day. Right? But there are some who would manifest later. And then you are in a conundrum after that.
So
what is happening is a surgical problem or it's an ERCP problem, it's very difficult to determine that.
Abhinav, as an endoscopist, can you predict which patients are likely or more likely to develop post-ERC and acute pancreatitis so that we can take more precaution? Maybe we can wait a little longer, as Dr. Rajan is saying.
Yeah. So young patient, repeated pancreatic ductal cannulation, pancreatic contrast injection, what we call arborization or acinerization of contrast is very high predictive value that we will land up with pancreatitis.
So Rajan Saxena, PGI boss.
then need for hemostasis at papilla, where we use coagulation, that these patients can lead to pancreatitis. So multiple, time taken to cannulate. Recent is that even if you don't cannulate pancreatic duct, but if you spend more time on papilla, simply fiddling with papilla leads to increased risk of pancreatitis.
So although most of our audience is surgical, but I think surgical students should know what are the methods you use to prevent post-ERCP pancreatitis.
So the problem with post-ERCP pancreatitis is that even after this parameters, suppose patient is not young and we have not fiddled with the papilla much, still pancreatitis may happen. It is totally unpredictable. It is kind of anaphylactic kind of reaction. But to mitigate that, if the risk factors are there, like previous biliary pancreatitis, earlier we used to do sphincter Oddi manometry where pancreatitis rate was to the tune of 30-35%. Or if young patient is there, or if cannulation takes longer time, if we have put in a contrast, multiple guide wire to pancreatic duct, then the protocol is hydration. Then we can give rectal endomethacin, drain out whatever contrast is gone into PD and put in a pancreatic stent. These are the measures which we can utilize to reduce risk of pancreatitis. But I'm saying it again, these methods are not foolproof. Still pancreatitis might be there. So these are the cases where I think we should wait for at least 24 to 48 hours before embarking upon that policy.
Professor Kapoor.
Yeah, please, Dr. Iqbal.
Good evening, sir. So first of all, congratulations for this wonderful initiative. It's really going to be helpful to the students. Now I have got two questions for Abhinav. I hope you won't mind. The first is that in the recent times, we have had two cases where the basket was impacted. Do you feel that the quality of the baskets is deteriorating on day-to-day basis? Because it did not happen for the last 10 years and suddenly two cases. And it's very tough cutting this basket. We had to use those very heavy scissors. We took them out through the port and then we cut the basket. Very tough. Yeah. What do you feel about the baskets? Are they deteriorating?
Scissors are not recommended to cut the basket. You should have wire cutter, and that to a newer one in your endoscopy room, because these wires cannot be cut using scissors.
It's so not those scissors that we normally use. So no. Yeah. The heavy ones, we had to get the biggest possible scissor, and then we could cut them. It was not possible otherwise, because it had never happened. So do you feel the baskets are deteriorating in quality?
Yeah, yes. So local baskets from local companies, they are not up to the mark. Two problems there. Ideally, basket, all 4 wires, they have bulbous tip, and basket should break from that tip. Suppose if you get infected, and suppose if you are doing lithotripsy, if the stone is too hard, if it is not breaking up, then at least basket should break and all those 4 wires should open up. But if that tip, solder tip, is very is not of good quality, then basket will not break and basket will get infected. So off late the cheaper basket which are coming up in the market, the problem with those baskets are they get deformed very easily.
Definitely.
Even with first ERCP, they will get deformed and they have unpredictable breakage. Sometimes the basket remains intact, the wire breaks down. And if the basket is hanging in the CBD, you don't have any access to the basket. Also, patient lands up with surgery. So yes.
My second question is, have you any experience of doing ERCP in patients of situs inversus?
No, not yet. Not yet. But
we have had 2 cases, and in both the cases, unfortunately, our endoscopists, they could not cannulate because of the turns, and believe me, it was very difficult operating those patients, but definitely it's something that we have to keep in mind once we are going.
And only such case was being demonstrated in AIG Endocon last week only, and operator who is a very skilled one had difficulty. One of the trick which I was discussing with senior people like Professor Sharma. Yeah. So one of the trick is you do it in right lateral position rather than left lateral position. That is the trick which is suggested for situs inversus.
Thank you. Thank you very much.
Abhinav, can I come in here?
Yes, sir. Yes, sir.
One more trick which I heard from an endoscopist in Milwaukee. He has some experience of doing on 2 or 3 cases. situs inversus cases, he
Yes,
says,
sir.
I don't use the side viewing scope is there.
Yes, sir.
He prefers to go with a straight viewing scope to get to the papilla in patients with situs inversus. The anatomy is just the reverse.
Straight viewing is straight view endoscope doesn't have elevator. So therapeutic options they
He
get
could do it without the elevator because it was such a direct access.
Yes, sir.
He said, I waited with the side viewing scope and I tried, and then when he failed, then he got an idea, let me try it with this one.
Yes, sir.
And he could manage it straight away.
Yes, sir. Good tip. I will try in next week.
Just remember it, if ever you are in trouble, try it out.
Yes, sir. Yes, sir. Yes, sir.
The second thing to
Great.
Dr. Iqbal, why scissors are not recommended to be cutting the wires when they get impacted. If you will look at the Domia basket, these are multiple wires,
Yes, sir.
minimum 4, which
Yes,
are joined around each other all through the length.
Yes, sir.
And wire cutter is the only thing which will sever all 4 at the same time.
Yes, sir. Yes, sir.
That is the reason why wire cutters are recommended.
Yes.
So Abhinav,
Professor
Yes, okay,
Rajan.
Yes, yes.
Yep.
Professor Rajan, basically, it was a first time experience with us. We had a patient with a wire coming out and through the mouth, and it was quite difficult for the patient to be.
Panic
In fact,
situation.
we shifted next day, and then he pulled it out through the port, and then we were at a loss. How do we cut this? Then we got those big scissors, which we use for cutting. I mean, gauze and everything. That was the only thing we had available.
Well,
That
I'll
time.
tell
It
you.
was a new experience.
If you have a CBDS OT next to you somewhere or an orthopedics OT, just ask them for a wire cutter and that's it. Don't
I
have to
hope
look
we
for-
never face it. I hope we never face it
No.
again.
You should always be armed with one experience. It is always wise to be secure about this thing. It's a very inexpensive instrument. But
True, sir. True, sir.
Abhinav, one more question. Would you recommend that after an endoscopic intervention for CBD stones or for any other indication, should we do a serum amylase lipase as a routine the next morning or only in selected cases?
So routinely amylase lipase will always be elevated if we fiddle with papilla. So that is not pancreatitis. Even if it is 1000, it is not pancreatitis. Pancreatitis is a clinical syndrome which happens after ERCP only if symptoms are there. So we have to go for symptoms rather than amylase lipase values.
That's very important for the students that surgical students, the moment the patient comes back from the endoscopy suite, you have to ask the patient whether the patient has any undue pain. You have to examine the abdomen and you have to re-examine the abdomen the next morning also before you take the patient to theater, because the consultant is going to come to the theater when the reports have been put in. It is your responsibility to examine the patient the morning before the patient is taken to theater. If there is any doubt, if the patient is having undue pain, is having nausea, is having any abdominal signs, please get, as Dr. Abhinav says, serum amylase lipase done. Tell your consultant that we should reevaluate this patient. Maybe as Dr. Rajan suggested, don't do the lab chole even the next day. Wait for another day. Make sure that there is no post-ERC pancreatitis, because if this patient is having post-ERC pancreatitis, after lab chole, it will be very difficult for you to know whether the unsettled patient is because of pancreatitis or because of a bile leak and bile duct injury and bile leak. So this is very, very important. And second thing I already pointed out is the instruction, verbal as well as written, for removal of stent. So any other panelists would like to make any comment? Otherwise, then I will...
Vinay, just a
yes,
question
please.
to Abhinav.
Yes, please. We
Abhinav.
have 3 minutes.
Hello, Abhinav.
Yes, sir, listening.
यार एक सवाल का जवाब दो. ये
Yes, sir.
पेशेंट जिनको ERCP के बाद पैंक्रेटाइटिस होती है, it's an observation that they have an exceptional high grade of nausea following ERCP, which I don't see in other patients. Is it
Yes.
correct?
Yes, sir. Yes, sir.
Right.
They have some kind of uneasiness, restlessness in the abdomen, which they think that if they vomit, they will ease it out. But that doesn't happen.
Doesn't happen.
Sir, I have a question. Like,
Yeah, Peeyush, please go ahead.
if for whatever reason CBD clearance is not possible, or you have just put in a stent, so what will be the minimum time period for after which a second endoscopic should be attempted?
Yes, very important.
Minimum 4 to 6 weeks.
Okay.
Because stent moves up and down CBD with the duodenal peristalsis. So this friction softens the stone and sometimes breaks it up. So, 4 to 6 weeks is required for that mechanism to happen.
And during this 4 to 6 weeks, sir, is there any role of putting a patient on UDCA?
Yeah, there is a study of stent plus UDCA also, and it tends to favor UDCA plus stent.
Okay.
Yeah.
Thank you,
So
sir.
it's 8:59 and we have a tradition of starting at 7 and closing at 9. So I would like to thank Dr. Rajan. And Dr. Rajan, we hope to see you in both Jaipur surgical tutorial and master classes, because you have served a long innings at SGPGI. Now you have moved out of SGPGI, but I think the teaching itch we all have, you still would continue to do that. So we would hope to see you again. And I would like to thank the three speakers, Mohammad Younis, Peeyush, and Abhinav. And I also thank Dr. Iqbal and Monica for joining, although they would be joining us tomorrow again as panelists. So thank you all very much. And I would like to thank the IT team of Dr. Avinash Nak. Himanshi, are you there? Can you please come in?
Yes, sir.
Yes, sir. Yeah, Himanshi is the foundation, she's the strong foundation of all the online educational activities. She does all the recording, all the uploading of the videos on the YouTube and on the Gastro University channel. So thank you very much, Himanshi and Avinash. And see you tomorrow at 7. Tomorrow, I have a personal social commitment. So I've requested Dr. Ibrar and Dr. Iqbal to please start and moderate. Now you know how to go about it. So I may not be able to join tomorrow. Please hold the fort. Thank you all. Thank you very much. Good night.
Good night. Thank you.
Good night.
Good night, sir.